So thank you and welcome to another one of our AAN webinars. We've had a number of these. This is brought to you by the AAN's academic initiative. Happy to be here. We've done a number of these. I think some of you have been with us for these others. We focused quite a bit on COVID in the beginning when we started these in April and had a number regarding COVID. And then we had reactivation ones in the post-COVID surge regarding clinical operations, education, and training. Next slide. We also dealt directly with addressing systemic racism early in July, and then had others that we have continued to push out. Financial repercussions of COVID, and then resetting research operations within neurology departments during COVID. But we've also made it clear that the AAN academic initiative had a number of things that were in the works from our chair summit that was canceled due to COVID. And so we've continued to work on other webinars. And we had this one on learning from lessons learned from the long-term EEG and preparing for the changes in reimbursement for E&M coding. And all of these are available on AAN.com and the AAN YouTube channel. We have a couple others in the planning phases that we'll be telling you about shortly in the future. Next slide. So today we're going to focus on faculty compensation models. And this was something, again, that many of the panelists that are here today had keyed up and were working on with their academic business administrators and as chairs working together to kind of look at and compare and contrast and provide best practices for faculty compensation models. This does not address funds flow. We've had a separate set of webinars and work that we've done on funds flow. And actually, Andy Josephson and Larry Goldstein, who are here today, are authors on the paper that was published that dealt with funds flow, getting the money to your department regarding clinical research and institutional revenue to your department. This webinar is more focused on if you have the money now in your department, how does it get distributed by either department-based or institutional-based faculty compensation models? We'll touch on the base as well as incentives, and we're going to also try to touch on even some models for annual adjustments, benchmarking, and even approaches to non-clinician or non-physician compensation. So we labeled it trials and tribulations, and as you'll see in a moment, you've seen one faculty compensation plan. You've seen one faculty compensation plan. There's a lot of variety out there. Next slide. I have a great group of panelists with me today. Merit Stokovich is with us from Mass General, Larry Goldstein from the University of Kentucky, Andy Josephson from UCSF, Sheila Fassell from Boston University, the business administrator there, Russell Starkey, the business administrator at Hackensack Meridian Health System, Matt Stowe, the business administrator and chief of clinical administration at University of Kentucky. And then Becky Wolf is here from the AAN. We'll talk a little bit about our neurology compensation and productivity survey and that resource that we have available to you as well. Next slide. So what we thought we would start with is, as I mentioned, there's a lot of variety, and you'll see in a moment. We've asked each of the 5 panelists to just briefly go over some standard questions and some standard approaches to their faculty compensation models, and particularly some of the challenges that they may have. And we'll go through those just as an introduction before we get into the questions. So I think first up, we have Andy Josephson from UCSF. Andy.
Great, thanks, Ralph. We can have the next slide. We're all starting off with these standard questions. So my department's greater than 60 faculty, about 250, a large department. The compensation plans are departmental rather than something that the institution mandates. We do have a set formula, as we'll talk about. There's some salary variation by subspecialty, not a huge amount, but some. This next question was meant for us each to address: when you hire new faculty and they come in at a salary, does that change the entire salary structure for everyone else, an adjustment for everyone? Answer at our place is no. And we do have an incentive plan. We have incentive plans for clinical work, research work, and for educational work. Next slide, please. So briefly, in one slide, our complicated compensation plan is pretty simple, I guess. The clinical portion of the salary for our faculty members who have a clinical effort is paid for per RVU that the person generates. And at our place, the entire institution sets an MGMA benchmark. We're at the MGMA benchmark. We started at the 50% MGMA benchmark, and now it's moved up close to the 75th percentile. Other portions of an individual's salary, research, education, administrative, diversity work, are negotiated separately with our department based on some known benchmarks that we have. We do have these incentive plans, as I mentioned, which we call Z payments, that are paid at the end of the year for clinical education and research work, which I'm sure we'll come to. Something that, as Ralph will tell you, is going to be part of a separate webinar that we're planning, so I've skipped the details, is that we at UCSF go through a real deep dive every year in terms of data, both in the department and across the entire medical school, looking for equity in the department in terms of salary, both as a department and at the individual level. And if there are inequities determined, particularly based on gender or activity or underrepresented in medicine status, we make adjustments as needed. There's a number of challenges and risks to this model. I think the biggest one is that RVU multiplier, if you will, how many dollars each RVU is worth, is set by the health system every year. So that is at some risk, although we're paid on a 3-year rolling average. So a change wouldn't make a change immediately that affects people severely. And then finally, our model doesn't really pay salaries based on seniority purely. That for us is good because it allows us to pay our junior folks more, but you don't necessarily get more money every year that you're on the faculty. So that's a brief look at our plan, Ralph.
So we're going to move now to Russell from Hackensack. Next slide, Hackensack Meridian, and you're going to tell us about your program, Russell.
All right, well, thank you very much. If you can move to the next slide, please. Okay, so at Hackensack Meridian Health System, it is a 17-hospital health system with over 60 faculty in the Department of Neuroscience. The compensation model is at the institutional level, and it is a centralized approach in terms of how comp is rolled out. It's rolled out across the health system fairly and managed the same way across all departments. We do have a set formula, which we'll discuss in a moment. In terms of salary variation, there is some salary variation by subspecialty, but I'd say it's mainly driven based on MGMA classification, which we are starting to bring that down because the epilepsy classification and them losing work RVUs is now moving them closer to general neurology, and we're starting to move them into that bucket. So that's starting to fade away. In terms of market adjustments for new faculty that are hired, there is no adjustments, but everybody's on more or less a 3-year term. You can negotiate 2 or 1-year terms, but those are not as frequent. And if there is changes, you can do that at renegotiation at that time. And do you have an incentive plan beyond base salary? The answer is yes. There is a couple incentives, including a work RVU incentive, a quality incentive, and then an ACO incentive as well. Next slide. So I'm going to cover the model that's instituted here at Hackensack Meridian Health, which is the CARTS model, which in terms of how this works, this is broken down into the mission support areas of the health system. So clinical is running through the physician practice enterprise, and basically your clinical salary, whatever your effort is there, will set your work RVU threshold. Your admin is something that can be assigned by the hospital or the practice leadership. So if you are given a chair title or a director or chief of a section, you may get a 10% effort associated with those admin dollars. Your research is salary protected by grants or industry-sponsored studies. And basically, the dollar amount that buys your time out of your base salary gets backed into in terms of effort. Teaching, dollars that are paid out by the School of Medicine are allotted. And then there's also, we do have various campuses. So we do have some campuses that are more teaching. But in terms of those that are higher teaching, a portion up to a maximum of 10% may be allocated. And then strategic dollars, you may be assigned to a larger organizational mission critical role such as being ahead of the IRB, and that would maybe potentially fall into that bucket. So I'd say the strategic bucket tends to get used the least, but those are basically how it gets broken down. So once you break down your efforts into these categories, you're going to take your clinical effort and divide by your dollar per work RVU rate. Similar to what was said previously, we are using MGMA and having a blended rate of the private and academic as a dollar per work RVU, and we are looking at the 75th percentile as well. In terms of incentive paid for any production above threshold, that's how work RVU production will dictate that. And if you were a provider that was only 60% clinical, you would adjust your threshold down based on being a 60% effort. If you're 100% clinical, you'll have a higher work RVU threshold to hit to earn incentive. We do also have quality measure incentives that are set by the practice. And then the organization as a whole also does have an ACO shared savings that does get distributed out at the end of a year. Some challenges associated with this is that production-based contracts can create inequity of total salary for those that are more focused on research and teaching. So, there's some concern around, are you diminishing the academic mission if people are, more incentivized to earn a higher total salary? Funding from research and teaching may be underrepresentative of true effort. So, they are looking at the total dollars funded, but your actual effort may be more than that. And then ensuring that the total salary does not violate grant restrictions. For the most part, we're fine in this territory. Usually people are either, for the most part, on the higher end of being almost purely grant funded with very minimal salary effort or clinical effort. But so it tends to not be an issue, but that can happen depending upon total salary and directorship roles.
Great, thank you, Russell. That CART model makes sense when you think about missions. One quick question for you that I heard. I thought I heard you say, and we're going to talk about incentives later, the threshold. Did you say they have to get the 75th percentile before they pass that threshold? Or do you use
the dollar per work RVU rate is set at the 75th percentile. And so if, let's just say that it's paid at $65 and your clinical salary is $200,000, you're going to take $200,000 and divide by $65 to set your work RVU threshold.
Got it. Okay. Let's move forward, and we're going to hear now from Merit regarding Mass General.
Thank you. Next slide, please. So we have more than 60 faculty. We have 330 faculty, of which about 120 see patients, either full-time or part-time, with their other part being research. We are department-based comp plan. We do have a set formula. We do have some variation between subspecialty. We do not do market adjustments when new faculty are hired. And we don't really have an incentive plan aside from, as you just heard from prior speaker, of we do pay out surplus RVUs earned when people go over their clinical target. Next slide, please. So our comp plan is RVU based, and you need to be eligible for the comp plan. You have to have a primary appointment in our department, and you have to have an annualized base compensation of at least $30,000. So it's largely, we have mainly full-time people, but we do have a few part-time people. So we set that minimum threshold, and the comp is divided into 5 parts. It's a bit like CART, but not called CART, in that people have a research salary. They have their clinical effort that is totally RVU based. We have Harvard Medical School rank-based stipends, and that's to cover teaching. We have administrative stipends for roles such as division chief or unit chiefs or different committee leaders. And then there is chief's discretionary stipends, and those are used to support people, to try to get people to the same target you heard from the prior speakers, a 75th percentile. We have some unique challenges in Massachusetts in that there is a ceiling on percent increases in payments that insurance companies contract, which is roughly 2%. And so that leads to some financial challenges for the departments. We aren't really easily able to give cost of living adjustments. So even though our target is the MGMA 75th percentile, this can be challenging to get to. And it actually ends up that people tend to can have a higher salary with research than clinical. So the incentives are challenging. And then we do have, because of those lower salaries, it's harder to compete with private practice and other opportunities for our faculty. Thank you.
Great, thank you, Merit. And there are questions coming in we'll deal with. We're going to be talking about some benchmarks and some incentives in the future. So let's move forward to Sheila, another one that has a Massachusetts challenge. Sheila from Boston University.
Hello, everyone. Thank you. So at Boston University, our department is greater than 60. We have about 110 faculty. It breaks down to about 50 who are clinical, 50 research, and about 10 APPs. Our compensation plan is developed by the department. We do have a set formula, which I'll review in the next slide, which does include variation by subspecialty. We do not currently offer market adjustments when new faculty are hired, and we do have 2 forms of incentive, which I'll discuss next. So I did try to put this in a nice little table to summarize it a little bit. So our base salary for our faculty includes a number of different factors. So we benchmark against the AAMC median. Then we include an adjustment for academic rank, as well as subspecialty. And we also have an annual adjustment based on years of experience, which is accelerated in the first 10 years and then flatlines after that. The way that our comp plan is structured, most faculty start at 50% base salary guaranteed. This increases based on if there's any other funded time that can be either research, education, or administrative. And then the other 50% is at risk, and that breaks down to 20% based on RVU productivity. 26% is clinical metrics. This includes things like completing target clinical sessions, closing notes on time, patient experience scores, and then 4% is professionalism, which is attending faculty meetings or grand rounds or completing other compliance requirements. We do have 2 bonus opportunities. One is a RVU bonus. So if faculty goes above their target, they'll get a flat dollar amount per RVU. There's also an academic bonus where we set aside a pool of funds, and then each person is able to complete an academic scorecard where they keep track of different activity that might include teaching or other activity like submitting grants or being part of professional organizations. And then based on the number of pools that they get, the number of points that they get a percentage of the pool. So some of the challenges that we have with our compensation, I think some of this is around kind of long-term sustainability. So for example, increases in academic rank or promotion is funded by the department bottom line. We don't get any other source of funds for that. Our academic bonus pool also is only funded if there is a surplus in the department performance. Right now, our advanced care practitioners are not included in our compensation plan. Most of them are actually hired through the hospital and are part of a union, and they set their salaries. Right now, our compensation plan, the full scope of it only applies to faculty which have some amount of clinically funded time. So it doesn't apply to faculty who are 100% research. And our RVU targets are based on historical performance, which can be tricky, especially if there's changes in how people are clinically deployed or changes in billing, which makes it a little bit difficult from year to year to make sure that those targets are fair.
Great, thank you, Sheila. And we'll be coming back to some questions that are in the chat box in a bit regarding incentives and market adjustments. So we're going to move forward now to the last comparison. Larry Goldstein and his academic business administrator, Matt Stowe.
Thanks. Next one. So we currently have less than 60 faculty, but we're scraping 60 by next summer, and that doesn't count APPs and secondary faculty. The compensation plan really is a combination of institutional fiats and then things that we can do within the department. So there is some some wiggle room there. We really don't have a set formula, but we are developing a set process. There is no dramatic variation by subspecialty, except that we do now have neurointerventional neurologists, and they have a different salary structure than the non-neurointerventional neurologists. We at least traditionally haven't had set market adjustments when new faculty are hired, but it does sort of irk me that I have full professors that have been here for 30 years that are now supervising junior faculty coming out of fellowships that make considerably less than those faculty do. So we're trying to adjust that. It's hard to do in 1 year, but as you all know, this is a real tough market right now for us trying to hire folks. They're just not out there. And we do have incentive plans that I'll show you on the next slide. There we go. So I tried to do this graphically, and we're moving to this model. We're in a transition year now, but this is the general sort of scheme. So on the left, these are the basic total clinical compensation. And the little boxes are not proportional in any way. They're just there just to hold the words inside. But you start out with an academic component. So what's the academic component? Those are all the things that we want people to do, but aren't specifically compensated. So for example, authoring research articles and participating in committees that aren't funded, being involved nationally. What we have is under each major category of activity, there's a point system, so that if you total all of your points at your academic level, you get that full academic component. If you decide, for example, that, I really don't want medical students with me because they're slowing me down and I'm not making RVUs, so forget that. Well, those points are not awarded, and then you have to make that up in some other way, usually through RVU activity. So the idea here is to incentivize that academic component, and the component increases depending on your academic level. So assistant to associate to full, but the points go up also, assuming that as you're going up those ranks, you're having more of these types of activities. So where's the total come from? So the total then comes from basically an RVU-based total that subtracts out these other components. So the other components are things that are buyouts. So for example, if we have a full professor and associate professor that has an endowment, and that endowment is covering portions of their salary, that's to protect their time. So then that gets subtracted out from that RVU total. If they have health roles in UK healthcare, in the healthcare system, for example, medical directors or administrative roles that the healthcare system values and is paying for, then that gets subtracted out from their expected clinical activity. Same thing for college and university roles. If you're on a university committee for which there are funds flow associated with it, then that gets subtracted out. Same thing for GME roles. If the College of Medicine is supporting a program director or a clerkship director, an MS4 development director, those get subtracted out. Then we have a variety of different contracts. Contracts may have a set amount that we get per day, so that can get subtracted out of the total. Then there's supported research and other funded activities. And then again, this is not proportional, clinical activities. So for example, somebody that has very little in the way of buyouts, their clinical activity that they have to reach to get to that target salary is a lot more than somebody who has a bunch of buyouts, but those buyouts are covering them doing other things. So that gives the an annual expected remuneration. That's sort of what their target salary is. Like Andy had mentioned, this under this system is really not, the total is not based on academic rank. The total is based on for clinicians on clinical productivity. But that academic component does vary based upon academic rank. So that way we're rewarding and incentivizing, because if you don't do that, you know, the answer from your faculty is, what do I care if I'm an assistant or an associate professor? I'm paid the same, my activities are the same, what's changing here? And the answer is that I couldn't figure out how to answer that. So that's why we're having it reflected here. So that's the base. Then there are a series of potential bonuses. There's a productivity bonus, and that's based upon RVUs above the target. That's compensated at a given dollar per RVU rate. The dean gives the departments an academic bonus depending on making certain metrics. So that gets distributed again based upon a point system that's largely reflected there. And then there's a performance bonus that comes from the healthcare system. So that depends on the healthcare system making their targets. Then depending upon the faculty size and other things, they then funds flow back to us, and then we distribute that depending upon how patients did here. So the idea is to try to align the financial incentives with what it is we want the faculty to be doing. So when you add up their target compensation along with the performance bonus, academic bonus, and productivity bonus, that's where you get to their total compensation. So the things in green, those are buyouts from basically external or from other funds. And then the things in sort of tannish here or brown, those are things that we have to generate in order to cover in one way or another. So that it's again, we're evolving this. We're not quite there yet, but that's the structure that we're moving to for individual clinical faculty compensation. There's a separate model that's college directed for full-time researchers. So it's obviously a very different model since they're not making RVUs.
Great, thank you, Larry. And let's get rid of the slides now. Thank you, everyone, for showing that there is a lot of variation out there. There are some semblances of a base, and that CART formula comes across in some terms of kind of mission and time alignment with money. I'm going to go to some of the questions first before we jump into some other topics we wanted to cover. Some of the questions deal with benchmarking that I think we were just going to mention anyway, but what benchmarks do you use? And let's just do a quick round robin. Merit, what's your benchmark?
We use two, AAMC and MGMA.
Okay, and then Andy?
Yeah, same as Merit, MGMA for all our clinical work. Our non-clinicians, we certainly pay close attention to the AAMC.
Okay, Matt?
We're moving to MGMA for everything.
Sheila, how about you?
We use the AAMC.
Okay, and Russell?
We use MGMA as well.
Okay, we're AAMC mainly, and then there's $1 per RVU. There was other questions here about up and down in terms of, we talked about rank, but a question specifically at UCSF, do faculty clinical salaries change up or down annually? Andy?
Yeah, they do. So all faculty salaries are sort of readdressed once a year. It begins with a discussion between the faculty member and their division chief, then eventually comes up to me. That's when we put that equity review in as well. And, a lot of the adjustments in salaries, very little down, almost always up or staying the same. And those adjustments are based on different sources of income. And if you're going to do more, clinical work, that's one way to get it higher. If you get additional income through endowments or research or some of these educational RVUs, I'm sure we'll be talking about another way. So once a year, they're all readjusted.
Right. And I guess just to follow up, because UCSF had a couple other questions here about, is there a base salary that you have, or is it all these components?
Yeah, so everyone has a base salary at all the University of California hospitals, but it's a very small fraction of your total salary. It's actually used mainly for retirement purposes, and that does increase slowly over the years. I think the other way I think of that question is any of the salary guaranteed? In our place, it's all guaranteed. So whatever that salary is set, you're going to get paid that amount. If you exceed it, in terms of sources, then you can get these additional incentives. Part of the discussion every year is, well, geez, did your salary sources cover your salary? If not, we have to have a discussion about those sources or that salary.
So then that's where the following year's salary could go down. But in the middle of the year, do you ever give a warning that you could get a reduction?
Yeah, so we talk about where people are. It is actually against the policy of the institution to make any adjustments mid-year. So whatever you are for the entire year. You can't move up, can't move down, other than incentive payments, of course. But we do keep an eye on it. And if people are at risk for not covering their salary, we have a discussion. But again, it's very rare for us to have anyone go down every year. It's either stay the same or go up has been the usual way this has played out.
So I mean, at our place, if your productivity is off in the work RVU estimates, you can get a warning and a 4-month notice of a potential 10% reduction. Anybody else can get reduced in the academic year if productivity is off? Anybody?
Oh, I add that we don't reduce mid-year, but we do have a 10% withhold on the clinical payment, so that if somebody is behind at the end, they're not paid that money. And if they are, then they get it at the end and anything extra.
And it sounded like, Sheila, you had some at risk. So that at risk, is that on an annual basis or could it occur during the year?
It's on an annual basis. And it's based on the performance from the prior year.
Okay, great. We wanted to also mention about subspecialties. And so first, I want to hear from Merit. How do you deal with different subspecialties, including pediatric neurology at MGH?
Yeah, so we have for the RVUs, we pay more for outpatient work, for E&M work, and less for inpatient, and that isn't a way of kind of reapportioning the funds, or there's some other words for that. But the whole department understands that we can't be a great department if we don't have pediatric neurology or some of the other non-procedural specialties. So that helps, and we also go to the hospital for support, particularly for PD neurology. Because we can't, otherwise we really can't make their salaries on just E&M outpatient care.
I think for subspecialty, I know we do make differences, like critical care is definitely going to be higher, stroke. Obviously, if you have interventionalists like Larry mentioned. So there are some subspecialty differentiations in salary. And, you know, the AAN has tried to focus on this. So I want to just turn to Becky for a moment. I think she's here somewhere, to tell us a little bit about the AAN Neurology Compensation and Productivity Survey and what kind of resource that can provide regarding subspecialty salaries.
Yeah, thank you for the opportunity to talk about this. So every other year, the Academy conducts a survey to capture the benchmarks for compensation, both dollar values, but for also measures for compensation plans, benefits plans, and those types of measures, productivity, work RVU benchmarks, patient volumes, and also reimbursement for things like on-call services. Our last survey was conducted in 2019, and we had the highest response rate ever. It was 3,200 responses, or just over, and we represented 18 subspecialties, so very pertinent to this conversation. You can get some more subspecialty data that isn't available in some of the larger benchmark data sets out there. Our next survey, I see my date flew off the screen, but our next survey launches March 8th of 2021. So it's coming up quick. We're going to have the same benchmarks that we had in 2019, but we're going to add some more, getting more details about telemedicine and also trying to capture the impact of the COVID pandemic. So I know someone had mentioned, you know, that those benchmarks are often, you look back and they can change year over year for external factors. So this year in 2021, we're really trying to capture that impact of the pandemic. It's very easy to participate. It's completely anonymous and secure via an online platform. It takes about 20 to 25 minutes for an individual participant, but administrators have been instrumental in the success of the benchmark data set, and they are able to respond on behalf of their entire department via a spreadsheet they can download from the platform, fill it out for the department, and then re-upload. And the nice thing, the AAN can store that spreadsheet for easy year-over-year participation. Instead of having to fill it out every year, we can send it back and just edit. The other nice thing that every participant gets free access to the entire data set. So there's no cost if you participate for this large neurology specialized data set. It's presented in an interactive dashboard, which allows you to filter the data to be the most meaningful for your department. So you can filter by subspecialty, by clinical FTE, by academic setting, by academic rank, and there's a lot more filters. Of course, the AAN data team is always available to make sure we can run additional queries and really get you the data that you need, which makes us another unique product. So we're seeking your participation again, March 8th. AAN Communications will have more information about how to participate, but you can find more information right now on aan.com/benchmark or emailing benchmark@aan.com.
Great. Thank you, Becky. And it is a great source of data, particularly for subspecialty, you know, the MS, the epileptologists. Obviously, the epileptologists may change with the RVUs, but there's some great data in there. If we can get rid of the slides. We got a couple questions on teaching, and then I was going to also pivot to research. There was a question up here is, how do you determine teaching dollars? Who wants to take that one? I know I heard about, you know, clerkship directors and residency program directors. You may have some, quote, protected time for that. But what about teaching dollars?
Right.
Anybody have teaching dollars? Or
Well,
ERVUs was also mentioned here. Anybody
Right.
utilizing
Yeah,
ERVUs?
so in that model that I showed you, that's goes into that academic component. So if you do teaching, you get points for that. So if you do a flipped classroom, and these are it's a matrix of different categories with different points assigned to it. So again, if you have folks who are doing teaching, they get those points for their the academic component of what they're doing. We had done EVUs a few years ago, but under that funds flow model, we really didn't have a way of compensating people for it, aside from just stealing money from somewhere else.
But for the administrative directors of your clerkship,
Yeah.
directors of your residency program, there may be more than one. There are some funds that could come in to protect them. Merritt, I saw you shaking your
I was going
hand.
to say, so
Go ahead.
all our faculty get a stipend for education that is rank-based, and even though it's called the Harvard stipend, it comes from the Department of Resources, and there's a base expectations of at least 50 hours a year, which isn't that much of teaching. Anyone who does more, you know, we piloted this initiative to basically pay our what we call master educators a stipend of about $40K a year, and trying to get that endowed. It's very important. So you really have your teachers freed up, but it's hard to support with clinical revenue.
Great. I want to turn to research because we touched on obviously a lot of them, clinical incentives, but for research. So first, Andy, a full-time laboratory researcher, how do you handle them in terms of protected startup time? How long? What do you do for the really kind of the bench laboratory investigator?
Yeah, maybe I'll put the K awards aside because I think we're going to come back to that later if I remember, and just think of folks post K. You know, we look at the AAMC benchmarks quite a bit, but you know, for the most part, these individuals start not only with lab space, but with a large startup package and a piece of guaranteed salary. And that guaranteed salary outside of the money that would be brought in with grants can occur from endowment. We have a lot of that. Can occur from some of our very small number of state-funded FTEs. And then there's some other hard money, if you will, that comes through the VA system and some that comes through the county hospital. So in that way, we try to make sure that all of our individuals in that particular sort of series, if you will, Ralph, have a fair amount of protected time and good startup package to begin.
And Merritt, what about the clinician investigator, somebody who's a hybrid, you know, maybe doing translational work, imaging, genetics, has part for that and in part clinical. How do you handle that research compensation?
Yeah, so their clinical part is the same as all the other clinicians, and then most of them are 2080, just like the lab people. And it's a lot of it's on soft money. It's on their grants and using those same benchmarks. But we try to use, again, philanthropy or endowments to keep people close to that 75th percentile. And we also, on the flip side, because sometimes people can actually bring in a lot of money, we don't let people get to like 100%. So there's some limits on the upper end as well.
Yeah.
But similar to lab-based researchers, clinical investigators need startup packages as well. They're often maybe a little less because they don't have equipment, but a good 3 years, if not more, of protected time and salary.
And Russell, at your place, if you lose research funding, what happens?
If you lose research funding, you're going to get redistributed in terms of your effort. So if you lose research funding, you're going to end up with being more clinical, and your expectation for clinical is going to move up. Your threshold will get readjusted based on that. So if you were 0.6 clinical, and then you lost funding, and now all of a sudden you've become 0.7 or 0.8 clinical, you're now going to readjust your salary and readjust your threshold, and your expectation clinically goes up.
And will that happen like pretty quickly, or will you have any cushion to have them as they think about rewriting their grant and getting it funded the next cycle?
So for the most part, the chair of the department will review this and basically suggest that I will protect you for a year to give you time. After that, we will make an adjustment. So if we're under a circumstance where you lost funding, you may have X number of grants you submitted and expect funding to come in. It just hasn't come to fruition yet. It'll get protected under the chair account.
And Larry, Andy mentioned the Ks and the pre-Ks. How are they handled in your department?
Yeah, we've all the chairs together have talked to our dean about this because that's the NIH salary cap and then the gap. So where's the gap coming from? So the dean has made this a priority for him. So he takes about 50% of the gap and reimburses the department from his funds. So then the rest of it, we obviously has to come from somewhere. So that comes off of the clinical margin that we get. So, I mentioned before that the total faculty compensation is based on that RVU based model. So we get paid, thanks to Matt's negotiation, at a much higher rate than we give the faculty. So it's that margin that we use to fund everything.
Okay, that helps. And we talked about the NIH cap. You implied, I know even in our department, you're above the NIH cap. There's either institutional funds, endowments, any other ways to pay. Obviously the NIH cap only pays a certain amount. And if somebody is 80% research, how do you handle paying above the NIH cap? Andy, what do you do at UCSF?
Well, you said it, Ralph. This is obviously a crucial issue, and we've really relied on our philanthropic funds to make this happen. I think they're the most flexible of funds to make that happen, and there's some other ways, but for the most part, we largely rely on philanthropic funds to make that happen.
Right. So we're going to move now to incentives. You each kind of mentioned some things about incentives. Some had them, some didn't have them. Sometimes they're bigger, sometimes they're smaller. How successful have these incentive plans worked, say for your place? Let me start with Russell on this one for incentive plans. Have they worked well? Do a lot of people get them, and are they rewarding?
I would say that this works fairly well, and it kind of goes along with the general bell curve. I've got some very high producers that are kind of outside outliers that are making a ton of incentive. And then I have a lot of people in the middle that are making incentive. And then I've got a few on the other end that are not earning their threshold incentive at all. And it does kind of vary by specialty a little bit. So I would say the Alzheimer's dementia section has the least likelihood of hitting their threshold. And that tends to be the case. So it does kind of go on subspecialty oriented production expectations, but that's mainly where the incentive comes in. And
that's clinical work incentive that you're talking about, right?
Right.
And then, go ahead. Sorry, Russell.
Yeah, and then there's two other incentives. One's a quality incentive that anybody's eligible for. So dependent upon that, that's dollars that are set aside in quality by the organization. And then there's also, because we're a large part of an ACO model, there are dollars that are shared to the providers as a proportion of shared benefit.
So
up
that's
to a
that health system model of what can come to your department and then be distributed appropriately.
Correct.
Merit, what about you? You mentioned incentive for clinical work. Is it something that your faculty enjoy? Does it work?
So I do think it works. We tried to incentivize, for example, seeing more news, so kind of paying more for that, and also that people can earn more than their base salary if they see more patients. And so it has worked and helped us with the access. And the hospital has quality incentives that I think are also effective. The one area I'd say that we tried years ago that didn't work, I'd be curious to hear other people, is around the research productivity. You know, we used to have people write down their grants and their papers and get part of the pool, but people didn't want to fill it out. And I think that maybe there's different incentives for research. They're not necessarily doing the papers or the grants, you know, for the extra $1,000 or so. So that didn't really fly. But I'd be curious to hear our other people.
So, you know, scholarly productivity gets
Yeah.
factored in annual reviews and can get into a little Z at our place, but we do have a research incentive as well. But Andy, what about you? Do you have a research incentive?
Well, we do. I mean, I think I agree with Merritt that it was always hard. The clinical incentives have just become so, robust that it seems silly to not do a research one. So we've actually done a lot of work on this in the short term. And what we've really decided to do, our departmental leadership has decided to focus on our junior faculty researchers, really the assistant and associate level, and sort of reward them for having a productive year. It's not very competitive. It's a pretty low bar. It has to do with publishing a paper as a first or senior author in a high quality journal and having it reviewed by a small committee. And if they do meet that bar, then a pool of money that we invest in this every year has been divided up. And it leads to a few $1,000s for these individuals, which I think in the setting of having so many people getting clinical incentives and in our place teaching incentives, I think it sends a nice message. But I agree with Merritt. I think it's very, very difficult to imagine how to do this equitably. And there are different incentives for researchers, but offering something for us has been, I think, quite effective in these few years we've done it.
And, and our research incentive plan actually, based on the institutional based plan, has worked in the last couple of years. If you have more than 65% of your research FTE covered, there is money that comes back to the department that can either flow into paying the rest of your salary if it's not funded, or going above if it is funded, from other means. So it has worked in some ways. Harder for the hybrid, better for somebody who's a pure researcher. But what about back to education, Sheila, teaching? Do you have any incentive programs for teaching?
Yeah, so that is part of our academic bonus pool. So folks can get points for doing lecture series or teaching sessions with fellows or residents or medical students, or even mentoring activities. And then that helps contribute towards opportunity to get academic bonus.
When we have teaching awards that are given out at the end of the year, the money isn't enough, but the reward is there. But there are other ways to recognize teaching as well and incentivize it. Larry, you talked a little bit about citizenship. How do you incorporate citizenship and maybe measures of quality in either incentive plans or in salary compensation?
Yeah, well, part of it again is in that academic component of salary. You can get points for being on the IRB and being on a university committee, being on a department committee, being on a national committee, where there's no set funds flow to the individual for that. But that's how we that's how we try to address that and encourage it. And also it's one of the criteria that we use in our departmental statements of evidence for promotion as well. So there are a couple of different incentives for doing that, both financial and non-financial.
Non-financial. There was a question here that we haven't really directly answered. I'm going to mention here. In the age of COVID, if your institution has taken a hit and/or your department, have there been any adjustments made due to the COVID challenge? And we've covered some of these in our other webinars, but anybody, I know at our place, our retirement plan, the whole institution, there was no donation to the retirement plan for everybody who worked at the university for this, academic year. But other changes occurred because of COVID, any of you?
Not in direct salary, but we too, we have a 2-to-1 match. The university matches $2 to every dollar, $2 for every $1 that the faculty puts in. They reduced that to 1-to-1 last
Okay.
year, but it's going back up. You know, there were
Yeah,
all
it's
sorts of
temporary.
other things that happened.
But
not-
nobody else, any other? I know, David, your chair at BU has mentioned some, maybe only the chairs, but not to the faculty themselves, Sheila?
Yeah, so some of our chairs and chiefs did take a reduction. We were able recently to pay that back, but for the most part, it's been flat.
Yeah, okay.
I'd say, you know, we kept all faculty and staff whole, but that keeping them whole is coming from the department. So in a way, they're letting us ride that deficit for a while. But that was important for morale. And there were cuts to leaders and VPs, both administrator and chairs for salary and also retirement. But that's all kind of coming back now.
Coming back, yeah, which is great. Let's turn now, I know we're getting late in time, to a couple other topics here. I wanted to mention non-neurology clinicians. And just to mention, we're going to be dealing also with this issue of equity before we can talk about non-neurology clinicians. Equity is a big issue, and we're going to be having a special webinar to deal with the gender pay gap, demystify the gender pay gap, and the backdoor deals. And we're going to have the whole Women in Academic Leadership group that are going to be dealing with this in early February. But what about neuropsychologists? We have them in our departments. How do we handle those salaries? Russell, do you want to mention what you do for neuropsychologists?
Sure. So, you know, when we first looked at neuropsychology, you know, people were just on base salary and there was really no upside potential for production. So we've really moved to looking at a model similar to the, you know, general faculty, where they do have a work review incentive. So we have gone to, you know, their survey feature of neuropsychology production, which is around 2,400 work reviews as a general benchmark. And then come into $1 per work review rate to set a threshold for them as well. They are getting credit for passing their boards as part of dollars that are kind of set into their additional dollars, but not a threat to their clinical work review threshold. And then 10, you know, for years of loyalty or years that you stay on board, we're giving you $1,000 a year towards that, and that doesn't impact your threshold either. So you're kind of earning some dollars every year. You have board incentive to pass that and maintain it. If you are a clinical director of neuropsychology, you will get you know, an effort reduction that resets your threshold, and then you are eligible for incentive, no different than your counterparts that you're working with in neurology.
We've also heard about advanced practice providers. Some of them are not in the incentive model. Some of them are. Andy, how do you handle the salaries and approach to advanced practice providers?
Yeah, well, similar to what Russell said regarding the neuropsychologists, of which we have a lot, our nurse practitioners that are hired by the department have a similar structure than any other faculty member. And some of them they're almost all purely clinical, but there's some who do other activities. Interestingly, like probably a lot of our departments, we have some nurse practitioners, for instance, who we work with who are part of the department, and some who are working with the department but hired by the health system. And they have a totally different model where they have a set salary without much of an upside. And so there's a real sort of push at UCSF to try to get all these folks on the same model. But currently we kind of have two different models within the quote unquote department.
Right. Yeah, because some, you know, are you know, institutional based or health system based versus practice based clinic advanced practice providers. Marit, what about in your department for advanced practice providers?
For the advanced practice providers, they follow the hospital scale for salary. They all just got a good market raise, but the funding comes from the department. I just want to throw out the clinicians, non-neurology clinicians we have in the department are psychiatrists. So we have some in our multidisciplinary, and they get paid on our comp plan when they're in our clinics, which I think is probably the only comp plan that might be better than another one in the hospital. So. And similarly, some of our like interventional neurologists are on the neurosurgery comp plan. So people kind of follow the comp plan of their specialty.
Right. Now, there was a question here about incentives for, quote, mid-level providers, which I assume are the advanced practice providers. I think we've heard some had incentives, some don't. Is that right? Anybody want to add to that? But and then there's a question here regarding benchmarks for the neuropsychologists. Anybody have clear benchmarks there? That's a tougher one sometimes.
Yeah, so there's the American Academy of Neuropsychology that puts out a survey annually, and you can, if you can grab that from one of your neuropsychologists that is sitting and paying dues for that, you can obtain that benchmark data.
Right. And we're going to be collecting, as Becky was mentioning earlier, we're going to be collecting data on advanced practice providers in our productivity and compensation survey. So we'll also be able to tell you about neurology, whether they're in practice or in academic settings, advanced practice providers in the future as we continue to amplify that database. There was another question in here about basic neuroscientists who are funded. I think we touched on this, you know, who have a lean year. I know we heard from Russell, and Russell was pretty tough about, but what about at other places, you know, Merit, you know, if somebody drops a grant, do you let them slide for a year?
Yeah, we hold them for a year. And actually, when I first became chair, I realized people were telling me the day before they were running out of money that they're running money. So we said, we now look at it every year, and we actually give like mentoring advice to anyone who looks in danger and some bridge funding. And that has really returned, you know, tenfold in investment to keep people funded.
Right. And Andy, how about you? Same thing? Do you have some?
The same thing. The only thing I'd add to what Merritt said is we also do sort of an every 6-month review of every PI's finances. And I think the thing we found, in addition to a lot of the strategies she said, is this, you know, people don't know when they're sometimes about to be in trouble. And so it's really been a very helpful strategy for people to understand the finances of what are sometimes just massively large labs.
Right. So again, there are a lot of questions. I don't think we can get to them all. I think this has been, you know, interesting discussion. We started with, you know, you've seen one faculty compensation plan, you've seen one faculty compensation plan, but there are some at least foundational building blocks here. We hope over the years with our academic initiative to maybe get some other papers out there that will give some further instruction, maybe some things about incentive plans, learn from each other, and in a future chair summit, I think we'll tackle this some more. But it was great to hear from all our panelists here, to hear from, you know, all variety of different departments, how they've handled faculty compensation, whether it's institutional based or whether it's department based, and including how they handle incentives. It's not an easy thing, we all know, and we're doing the best we can, particularly in some of these more difficult times. Again, I want to thank my panelists. Great job, terrific job. And I think the beginning part with going through the standard approaches to your faculty compensation plans were really, really helpful. I bet people were taking some screenshots. And remember, it's recorded, it's saved on there to share with others. Again, thank you. And listen, have a great holiday and get your vaccines. I'm sure the vaccines are being released as we speak. I hope we'll see a lot of people that'll be vaccinated soon, and maybe we'll have less webinars and some more in-person engagements in the future. Thank you and happy holidays.